Right. So, hello everyone. Good afternoon. So, I hope my audio and video is good. Can you please let me know in the chat box if we are good to go? Good afternoon, Dr. Sharon. Good afternoon. So, please let me know if my audio and video is good. Right. So, I think we'll start. So, so I think currently the audio and video is good, I suppose. Yeah. So, let us start the discussion. So this will be part 3 of the NEET PG 2024 medicine system-wise recall. So in the part 1 and part 2, we have already covered several systems. So today we'll be covering the questions asked from the respiratory system, GI, hepatology, infectious diseases, and certain other miscellaneous topics. So let us go to the questions one by one quickly. So yeah, this is the QR code of my academic Instagram page. You can stay tuned to this page. And this will be my academic WhatsApp channel as well. You can follow this as well. Now, coming to the questions one by one. The first question: what is the most common cause of death in patients diagnosed with idiopathic pulmonary fibrosis? So idiopathic pulmonary fibrosis, this comes under the category of interstitial lung diseases, and they're asking what is the most common cause of death. The options: pulmonary arterial hypertension, respiratory failure, lung cancer, and aspiration pneumonia. What do you think is the answer for this question? Well, when you talk about this condition, idiopathic pulmonary fibrosis, which is abbreviated as IPF, idiopathic pulmonary fibrosis. So this is one interstitial lung disease that is characterized by a progressive disease with a decline in the lung function. What about the prognosis? When you compare the idiopathic pulmonary fibrosis with a disease like non-specific interstitial pneumonia, this has got a poor prognosis. And you can see that the 3 to 5 year mortality of this condition, that is idiopathic pulmonary fibrosis, is almost 50%. And what is the most common cause of death? It is respiratory failure. So coming back to this question, the answer is respiratory failure is the most common cause of death in such patients. Let us go to the next question. A 40-year-old male presented to the emergency department with sudden onset breathlessness. Chest X-ray is performed and is shown below. On auscultation, what is the most likely finding in breath sound assessment? What do you think? Look at the X-ray, look at the options. Is it vesicular breath sounds, bronchial breath sounds, absent breath sounds, or bronchovesicular breath sounds? When you look at the X-ray, you can very well notice that there is a collapsed lung margin. Okay. And you can see a very well defined area of air collection, that is pneumothorax. So this is a right-sided pneumothorax. So what is the likely finding in the breath sound assessment of a patient with pneumothorax? Well, when you talk about breath sounds, look at this slide about the character of breath sounds. So in a healthy lung, please understand, in a healthy lung, what is the normal character of breath sound? You will have vesicular breath sounds, which is low pitched and soft. Why is it low pitched and soft? Because the alveoli will filter out the other frequencies and you will be able to hear low pitched and soft vesicular sound. Whereas in a diseased lung, you get the bronchial breathing. And what are the different types of bronchial breathing? You've got a tubular bronchial breathing that may be seen in areas of consolidation, as in case of pneumonia. You can have a cavernous type of bronchial breathing that can be seen in an area of cavity. You can get an amphoric type of bronchial breathing, which can be seen in a large communicating cavity, and this amphoric breathing will have a metallic quality. And there is something also known as bronchovesicular breathing. So basically, when you talk about vesicular breathing, when you draw it, so this will be the inspiratory part and this will be the expiratory part. You can very well see that the inspiratory limb is pretty much longer and the expiratory limb is pretty short, and there is no gap between inspiration and expiration. Whereas when it comes to bronchial breathing, you will have this the inspiratory limb, and you can see that there is an expiratory limb which is almost equal to that of the inspiratory limb, and you can very well appreciate a definite gap between inspiration and expiration, which is not there in a vesicular type of breathing. Whereas when it comes to a bronchovesicular type of breathing, you can see, yes, inspiratory limb, inspiratory limb, you will have an expiratory limb, okay, which is almost same as that of the inspiratory limb. But again, you can see there is no gap between inspiration and expiration. Now, when it comes to pneumothorax, you very well know that patients with pneumothorax, the auscultatory finding is absent breath sounds. So what is the answer? Option C, right? Let us go to the next question, right? So a 50-year-old male present with a 3-week history of non-productive cough and mild dyspnea. So total illness duration will be 3 weeks. Physical examination reveals dullness to percussion and reduced breath sounds over the right lower lung field. Chest X-ray shows a moderate right-sided pleural effusion. A thoracentesis was performed and a pleural fluid to serum protein ratio is 0.6, and what is the most likely diagnosis is the question. Now, you can look at the options: cirrhosis, congestive heart failure, nephrotic syndrome, and tuberculous pleural effusion. I'm very sure that you have all heard about the lights criteria, which is very important to differentiate between an exudative and transudative type of effusion. And what are the parameters included in the lights criteria? You've got the first point, the pleural fluid protein to serum protein ratio more than 0.5, again favors exudate. Pleural fluid LDH to serum LDH more than 0.6 favors exudate. Pleural fluid LDH more than two-thirds of normal upper limit for serum again favors exudate. Now, if any one of these points is true, any one of them, then it is characterized as an exudate. If you want to categorize something as a transudate, all these three should be negative. Okay, any one positive means it is exudate. But what is the problem with lights criteria? The problem with lights criteria is that around 25% of the transudates may be misdiagnosed as exudates. So what you should be doing is, once you have made a diagnosis of an exudate as per the lights criteria, you can also go for this particular modification. It's on the serum pleural fluid protein gradient. If it is more than 3.1 gram per deciliter, then what you categorized as an exudative effusion, you will have to change your decision and it is to be considered as a transudative effusion. In this particular question, since the ratio is 0.6, which is definitely more than 0.5, I am considering an exudative effusion here. Now look at the options. Cirrhosis, what type of effusion is seen? Transudative effusion. Congestive heart failure, again transudative effusion. Nephrotic syndrome, again transudative effusion. And what is going to be the answer? Tuberculous pleural effusion. Very important. Okay, it is an exudative effusion. Very, very important topic. And you very well know about the causes of transudative effusion that I have taught you in my lectures as well. Congestive heart failure, cirrhosis, nephrotic syndrome, peritoneal dialysis, superior vena cava obstruction, myxedema, and urinothorax. These are the causes of transudative effusion. Coming to the next question. 50-year-old male presents with an acute epigastric pain. So he's coming to the emergency department probably with an acute epigastric pain, and the laboratory tests show elevated serum lipase level. Now this is relatively a specific marker for pancreatitis. 3 days after clinical stabilization, he develops breathlessness. Now, in a patient with pancreatitis who develops a sudden onset breathlessness, what will you think about? If you remember my lecture on ARDS, acute respiratory distress syndrome, which is nothing but a non-cardiogenic pulmonary edema, I have taught you about the causes of ARDS. There are several causes that results from a direct lung injury and several indirect causes as well leading on to ARDS. And I have told you that pancreatitis is an indirect cause that can lead on to acute respiratory distress syndrome. And when you look at the chest x-ray, you are very well able to appreciate bilateral infiltrates which are more towards the lung bases, again substantiating the possibility of acute respiratory distress syndrome. Now look at the options. First option, aspiration pneumonitis. Now, is there anything in the question which says that the patient is having some sort of altered sensorium leading on to aspiration? No, hence I am not considering this. Pulmonary thromboembolism. Is there any history of prolonged immobilization or some sort of predisposing factor for pulmonary embolism? No, hence I am ruling it out. And also in case of pulmonary embolism, we have already learned what are the possible chest x-ray finding which is not matching here. Non-cardiogenic pulmonary edema, definitely high probability. It is nothing but your acute respiratory distress syndrome. And what about the fourth option, increased pulmonary capillary wedge pressure? Isn't this a possibility? No. Why? Because increased pulmonary capillary wedge pressure occurs in what type of pulmonary edema? Cardiogenic pulmonary edema. In this particular scenario, you are not considering a cardiogenic pulmonary edema, but you are considering a non-cardiogenic pulmonary edema, and hence option C is the answer. So all my dear students in the chat box, Pranesh, Megha, Indu, Sharon, Ananya, I hope all of you are clear with this. Just give me a thumbs up if you are able to follow, right? Let me go to the next question. A 50-year-old male presents with a 5-day history. So it's a relatively short duration illness of fever and foul smelling sputum. So probably you are thinking about some suppurative lung disease. Now, suppurative lung diseases, what are the two important diseases that you know about? One is bronchiectasis and the second is lung abscess. What do you think is the likely condition here? Since it is relatively of short duration, it is more likely to be a lung abscess, but let us go to the remaining part. Digital clubbing. Clubbing can be seen in both bronchiectasis as well as lung abscess. Now let us look at the chest x-ray, which might give us a better idea. Now chest x-ray is showing a thick walled cavity which has an air fluid level. So when you get such sort of a thick walled cavity with an air fluid level, you are considering the possibility of a lung abscess. Lung abscess. Is it going to be a pleural effusion? No, it is not going to be a pleural effusion. I am not seeing any sort of blunting of the costophrenic angles. That is not going to be the answer. What about empyema? It is more of a pleural based lesion, a peripheral lesion. That is not what I am considering here. You are not going to get a air fluid level in case of empyema as well. What about pneumothorax? No, that is not what you are seeing here. So the answer is quite obviously a lung abscess, right? Let us go to the next question. A 30-year-old male with a known history of bronchial asthma presents for a routine follow-up. The pulmonary function testing showed an FEV1 of 70 percentage. Now watch out, FEV1 of 70 percentage, which improved to 83 percentage after bronchodilator nebulization. Now tell me, what information does this give you? Tell me, my dear children, what information does this give you? It gives you the information of bronchodilator reversibility. There is a definite evidence of bronchodilator reversibility, right? Now, he is currently using a meter dose inhaler, albuterol daily, which is nothing but salbutamol. On further questioning, he reports experiencing symptoms at least twice a week and nighttime awakenings due to symptoms at least once a week. So tell me, is this controlled or not? Is the patient controlled on the meter dose inhaler? He is not controlled on the MDI. And you can see the patient is having scattered bronchi as well. So what do you think is the next appropriate step in management? One option is continue current management. No, the patient is currently symptomatic and hence you will require a change in the medication. Next option is add inhaled corticosteroid. This is definitely a high probable option. Let me just go through the other options as well, because inhaled corticosteroids are very crucial in the management of bronchial asthma, especially to control the inflammation. So ICS LABA combination. Although in this particular question, the patient is on albuterol, which is a short-acting beta agonist, but still it is usually a LABA plus ICS that is preferred. Next is switch to salmeterol, which is a long-acting agent. But again, if you compare option B and option C, if you compare option B and option C, well, my preference will always be an inhaled corticosteroid. Inhaled corticosteroid has to be the preference here. Okay, right. And if you look at this, I have taught you either track 1 as well as track 2. The latest GINA guidelines I've incorporated in my lecture, that is the QRP videos, the revision videos I've incorporated. In track 1, you will have the ICS formoterol, and in track 2, majorly followed in the developing countries, it is ICS SABA. And so what you have to understand, my dear children, is this is a patient who is having a bronchial asthma, not managed as per standard protocol, I would say, because the patient is on albuterol daily. But still, if I am asked to pick an answer here, for me, the best answer here will be inhaled corticosteroid. Why? Because that is more important in controlling the inflammation. And what about adding prednisolone? No, that is only in case of the step 5, and step 5 also in certain patients only. And this particular clinical scenario is not something where you are going to categorize as a step 5. So hence, my best answer for this question will be option B. Okay, there is no need of any confusion. Next question, what is the role of interleukin 8 in the pathogenesis of acute respiratory distress syndrome? So IL-8 is a crucial cytokine in the pathogenesis of ARDS. Now, what about the options? Activation of the macrophages, activation of neutrophils, promoting surfactant production, and recruitment of neutrophils. What do you think? So you can see that the role of interleukin 8, okay, the role of interleukin 8 and certain other cytokines is basically in the recruitment of leukocytes, especially the neutrophils, into the pulmonary interstitium and alveoli. Okay, so here it was not activation of neutrophils, it was activation of eosinophils in the exam. Okay, and option D was recruitment of neutrophils, and that is going to be the best answer. Okay, activation is almost similar to recruitment, so we did not have those two options. So the best answer here will be recruitment of neutrophils, which you can clearly see in this particular screenshot that I've taken from the Harrison's textbook. It is one of the many cytokines that are involved in the pathogenesis of acute respiratory distress syndrome, right? Let us go to the next question. 55-year-old male presents with chronic cough and shortness of breath. On further evaluation, a diagnosis of chronic obstructive pulmonary disease is made and a CT thorax is suggestive of pan-acinar emphysema. what enzyme deficiency is most commonly linked to this condition. This is an MCQ which has been asked even before as well, mostly as a factual question. Now, if you look at this particular screenshot again from Harrison, let me just try to compare centri-acinar or the centrilobular and the pan-acinar or the pan-lobular emphysema. The one that is frequently associated with smoking is the centri-acinar emphysema, which is more predominant in the upper lobes of the lung. Whereas pan-lobular or pan-acinar emphysema, which is involving the entire acinus, that is actually associated with the alpha-1 antitrypsin deficiency, and it has got a predilection for the lower lobes. But even this particular pan-lobular emphysema also may be aggravated by smoking. It's not that it has no association with smoking. Even a pan-acinar emphysema can be aggravated by cigarette smoking. So for this particular condition, pan-acinar emphysema, the answer is alpha-1 antitrypsin deficiency. Let us go to the next question. Okay, so what do you think is the answer for this? Grace, Tejas, Achyut, Stardust, Indu, can you just answer in the treatment of tuberculosis? Which scenario is an appropriate indication for using the shorter MDR-TB rifampicin resistant TB regimen? So this is very important because you have to be thorough with the latest regimen. I assume that you have gone through the latest regimen in the revision videos as well. Now, the question is specifically about a regimen. Okay. Now, I have taught you the algorithm. This one is the latest algorithm for the treatment of tuberculosis. So, when it comes to drug resistance, okay, when it comes to drug resistance, you have got the BPAL-M regimen. And if the patient is not a candidate for BPAL-M regimen, next thing that you should be looking for is the eligibility for the shorter oral regimen. And the particular question is asking about the eligibility for the shorter oral regimen. Now, this is the shorter MDR-TB, RR-TB regimen, which consists of an intensive phase and a continuation phase. And in detail, I have explained this regimen in the lectures. And here is the longer MDR-TB, XDR-TB regimen. Now, when do you prefer shorter regimen and when will you have to go for the longer regimen? So when the patient is categorized as maybe a rifampicin resistant, and suppose if there are no additional resistance detected in the various line probe assays, then you can go for the shorter MDR-TB regimen. And the next point is that if there is INH resistant, so when you have an INH resistance, it can be a resistance to the CAT-G or INH-A gene or maybe both. But if there is a resistance to either CAT-G or INH, but not both, that is when you can consider the shorter. But if you have a mutation for both, you should be considering the longer regimen. And another point is that fluoroquinolone resistance should not be detected in case of opting for the shorter MDR-TB regimen, because if there is a fluoroquinolone resistance, you will have to go for the longer regimen. Now let us have a look at the options here. The first one, rifampicin resistance with both CAT-G and INH-A. In this case, you will have to go for the longer regimen and not the shorter regimen. I am eliminating option A. Next is extrapulmonary TB like TB meningitis. Now this is something which I want you to know. What the guideline tells you is that when you compare the shorter regimen and the longer regimen, when you have got more complicated cases like certain extrapulmonary TB, like a TB meningitis, in that particular case, you will prefer the longer regimen, obviously, because it is a more serious condition. So if the patient is having an extrapulmonary TB like a TB meningitis, I would prefer the longer regimen as it is more serious condition. Next is rifampicin resistant, that is confirmed fluoroquinolone sensitive. Yes, if the patient is rifampicin resistant, but the patient is fluoroquinolone sensitive, yes, I can definitely consider this patient for the shorter regimen. And rifampicin sensitive TB, look, we are talking about a drug resistant TB, and the shorter MDR TB, RR TB is for resistance. So if the patient is rifampicin sensitive, then there is no point opting for the shorter regimen. You have to go for the DSTB, that is the drug sensitive TB regimen. Are you clear with this? Dr. Ananya, Dr. Sharon, are you clear with this? Yes. Let us go to the next question. Okay. Evaluate the following arterial blood gas analysis. The pH is 7.2. The PaCO2 is 20. Bicarbonate is 8. So which means add with all is definitely going to be a metabolic acidosis. Yes or no? This is going to be a metabolic acidosis. Right. Now, so I've already eliminated option C and option D. Now they're asking, is it high anion gap or normal anion gap? So what is the anion gap here? Sodium 136 plus minus the chloride plus bicarbonate, correct or not? So it is 136 minus 108 plus chloride plus bicarbonate. It is 8. So it is 136 minus 116, which is 20. So what do you think? Is it high anion gap or normal anion gap? Can you answer in the comment section? What do you think? Is it high anion gap or normal anion gap? High anion gap. So what is going to be my answer? My answer is going to be option B. It is a high anion gap metabolic acidosis, right? Okay. Let's go to the next question. Based on the following laboratory parameters, what is the likely diagnosis is what they have asked. So let us actually see the question. The arterial pH is given as 7.2. 1 second, let me just correct the video. Can you just wait? I'm just correcting the video. 1 second. Okay, right. So, yeah, we're back. So, based on the following laboratory findings, we have to find what is the most likely diagnosis. Let us look at the parameters. So, the arterial blood pH is 7.28. So, there is definitely acidosis, right? And you can look at the sodium 134, potassium 2.8, chloride 113, bicarbonate is 12. So, we are probably thinking about a metabolic acidosis. Metabolic acidosis. The blood urea nitrogen, creatinine, I think all of them are normal. Now, what about the anion gap here? So, anion gap is sodium of 134 minus chloride of 113 and bicarbonate of 12. So, 134 minus 125. So, the value comes to around 9. So what do you think? Is it normal anion gap or high anion gap? What do you think is the answer? It is a normal anion gap. So it is not high anion gap, already eliminating, correct or not? Now you can see the patient is having a potassium of 2.8. Now, if you look at the various type of renal tubular acidosis, you very well know that type 4 renal tubular acidosis, you get hyperkalemia. The potassium is usually increased in type 4. Now it is between type 1 and type 2. How to come to a conclusion? Is it type 1 or type 2? Have a look at the urinary pH. What is the urinary pH? It is 9. So there is a problem with the acidification of urine because the pH is high. And in which type of renal tubular acidosis is there a problem with the acidification of urine? It is in case of type 1 renal tubular acidosis, that is the distal RTA. So distal RTA patients, you will have the urine pH which is above 5.3. That is how you will differentiate between the type 1 and type 2 renal tubular acidosis. There will be a problem with the distal acidification, which because of which you will have a high urinary pH. Okay, the urinary acidification will be defective. So the answer is going to be type 1. Very good, as rightly said by Dr. Foliodiax. That's what you have named yourself in the comment section. That's a good name. Okay, right. So coming to the next question. So we have covered the questions of pulmonology, acid-base balance. Next, coming to this question, a 40-year-old male is diagnosed with systemic hypertension. He is having a history of renal stones and multiple episodes of renal colic. Which of the following diuretics is the most appropriate choice in this case? Now, in a patient who is already having a history of renal stones, I am not going to prefer furosemide. I am not going to prefer ethacrinic acid because both of them are loop diuretics. And always remember, loop loses calcium. Loop loses calcium. Calcium will come in the urinary tubules, and because of which there is more chance of stone formation. I'm not going to choose option C and option D. Now, basically, what I'm trying to choose is something that can reduce, the calciuria. That is, this renal tubular calcium. The calcium should not accumulate in the renal tubules. So thiazide, what it does is that it will cause reabsorption of calcium from the renal tubules. Okay, so hydrochlorothiazide is the appropriate choice here because it will help in reabsorption of calcium from the renal tubules, decreasing the possibility of formation of renal stones. And we know that hydrochlorothiazide is often given in the management of hypertension, mostly as a combination drug with another drug. It is usually given. Okay, right. Now coming to the next question. A 25-year-old patient with history of recurrent sinusitis, chronic productive cough, bronchiectasis, and several episodes of pneumonia and middle ear infection over the past few years. On examination, digital clubbing is observed and chest X-ray is shown. So you can see there is a history of recurrent sinusitis. Okay, several episodes of pneumonia. So when you have got recurrent infections, bronchiectasis. Okay, so there are recurrent infections, bronchiectasis, and as you can see in the chest X-ray, can you see the fundic gas shadow here and also dextrocardia here, showing that there is a situs inversus. There is a dextrocardia and the fundic gas shadow is seen on the other side. There is situs inversus. So when you get a recurrent infection, situs inversus, bronchiectasis, you are thinking about a primary ciliary dyskinesia like Cartagener's syndrome. Cystic fibrosis can have bronchiectasis as a manifestation, but the other points like the situs inversus does not match with any of the other options. Even tuberculosis can have bronchiectasis, but do you think tuberculosis will have situs inversus as a manifestation? No. Hence, my answer is Cartagener's syndrome. Next question, a 50-year-old woman with systemic sclerosis with progressive shortness of breath, particularly during exercise. Okay, right heart catheterization is showing a mean pulmonary arterial pressure of 35 mm Hg. So when the mean pulmonary arterial pressure goes above 20 millimeter mercury, what will you call this? This is nothing but a case of pulmonary hypertension. I am making a diagnosis of pulmonary hypertension. Yes. And what is the question? Which of the following statements is most accurate regarding her condition? The first option, calcium channel blockers should be the first line therapy. Well, in patients with pulmonary hypertension, do you think calcium channel blockers are the first line therapy? Answer is no. Please understand that calcium channel blockers in pulmonary hypertension is only given for a limited subset of patients who are having a positive vasoreactivity test. Only in those having a positive vasoreactivity test. In other patients, you are not going to give, hence this is not the correct option. Next, endothelin receptor antagonists are effective in improving the symptoms is a correct option, especially when you give it with drugs like phosphodiesterase 5 inhibitor bosentan combination is often useful in improving the symptoms. Next, early identification makes lung transplant the best treatment option. Again, is a false statement, because even if you identify early, that doesn't mean that immediately the patient has to be taken for lung transplantation. Lifestyle modification alone is sufficient for pulmonary hypertension? No, it is not a condition where lifestyle modification is going to do any sort of magic. You will have to go for aggressive medical management. Okay, so for this question, answer is option B. Let us go to the next question. A mother brings her 4-year-old child to the clinic due to poor weight gain, abdominal pain after meals, and a poor appetite. After advising the child to follow a gluten-free diet, there is noticeable improvement in the overall condition and growth. What is the most likely diagnosis? So all my children, when you look at the options, celiac disease, tropical sprue, A beta lipoproteinemia, Whipple's disease. What is common to all these 4 options? They are all disorders of malabsorption. But what is the only disorder of malabsorption that is going to improve after a gluten-free diet? Yes, it is going to be celiac disease. Such a simple question. My dear children, in the exam, it is all about picking up the buzzwords. It is a malabsorptive disorder, but the patient is improving after a gluten-free diet. Okay, right. Coming to the next question, antibody associated with celiac disease. Is it anti-tissue transglutaminase, ASCA, ANCA, anti-parietal cell? Well, all my children, I'm sure that you know the ASCA, that is anti-Saccharomyces cerevisiae antibodies, is associated with Crohn's disease. So the ANCA, that is the P ANCA and C ANCA, is associated with various vasculitis disorders, right? And then anti-parietal cell antibodies associated with pernicious anemia. And what is the only option left? It is anti-tissue transglutaminase, which is a common antibody that is being tested in patients with celiac disease. Okay, in patients with celiac disease, I think there is again a issue with the video. Let me just check it out. Okay, just give me a second. Right. So for this question, it's option A. So remember, NEET PG 2024 actually had 2 sets. So in one set, this particular first question came. In another set, again, this particular question came. So basically, for NEET PG, the high yield topics are very, very important, which is why you will have to watch all these recall videos and try to understand what are the high yield topics. Coming to the next one, a patient suffered from a blunt abdominal trauma. A relatively lesser number of questions this time from GIT hepatology. Okay, so patient suffered from a blunt abdominal trauma after a road traffic accident and subsequently underwent an ileal resection. So there was resection of a segment of the ileum. Patient recovered well, but months later the patient is having fatigue and reduced exercise tolerance. So when you have got an ileal resection followed by such symptoms, you are probably thinking about anemia due to a vitamin B12 deficiency, because vitamin B12 absorption, the ileum is very, very important. So there is a chance that this patient has probably developed a vitamin B12 deficiency anemia. And look at the options. Which of the following would not be expected in this patient? Nuclear cytoplasmic dyssynchrony in the developing RBCs is expected, because the cytoplasmic maturation will take place normally, but the nuclear maturation will lag behind. So this is not something that I would not expect. Microcytic hypochromic anemia, I am not expecting iron deficiency in this particular case. Iron deficiency is the one that presents with microcytic hypochromic anemia. In this particular case, I am expecting macrocytic picture. Romberg sign possible because vitamin B12 deficiency can lead on to a subacute combined degeneration of the spinal cord. There can be some sort of posterior column dysfunction resulting in a Romberg sign, and option D is also expected. So the one that I will not be expecting is option B, that is microcytic hypochromic anemia. Let us go to the next question. Another question from GI hepatology. Uh, a patient undergoing colonoscopy shows raised cream to yellow plaques and nodules attached to the colonic mucosa with intervening areas of relatively normal appearing mucosa. What the findings are suggestive of what? So if you look, when you get these yellowish mucopurulent volcano eruption like exudates, what possibility are you thinking about? You are thinking about a possibility of a pseudomembranous colitis. Pseudomembranous colitis, option D. It will show all these mucopurulent exudates just like a volcano-like eruption. That is what you are seeing in the colonoscopy. Option D is the answer. Okay. Now, a patient on with HIV on antiretroviral therapy is on zidovudine, lamivudine, and nevirapine. He is now newly diagnosed with active tuberculosis. Due to drug interaction, which of the following standard anti-tubercular medication should be substituted in this particular patient? So you can see the patient is on zidovudine, lamivudine, and nevirapine. Okay, now when it comes to tuberculosis, there is a problem with this particular drug rifampicin, because this drug rifampicin is an enzyme inducer. It is an enzyme inducer, hence it can dramatically lower the levels of drugs, especially a drug like nevirapine, which you have already learned in your pharmacology lessons along with drug interaction. So this will result in an antiretroviral therapy failure. So you will have to replace rifampicin with rifabutin, So the answer for this question is going to be option B because of the potential drug interaction, right? Okay. Let us go to the next question. A 27-year-old office worker who is frequently eats takeaway food. So you're probably thinking of some disease with a fecal-oral mode of transmission. Presents with a 7-day history of fever, fatigue, mild abdominal pain, and loose stools. And he's having a high temperature. And despite the high temperature, the pulse rate is only 75. What do you call this? Can anybody tell me in the comment section? I'm waiting for your answers as I analyze the remaining points. You tell me, what does this mean? In spite of a high temperature, the pulse rate remaining normal. And the patient is having several blanching macules as well on the trunk. Laboratory studies shows leukopenia, mild thrombocytopenia, and elevated transaminases. And the question is, what is the most diagnostic test in this particular case? Especially in the first week, patient presenting to you in the first week, what is going to be the gold standard? It is definitely the blood culture. Vidal test not in the first week but in the second week, but even in the second week nowadays Vidal test is considered to be more or less obsolete, not very specific, lot of false positives, and hence I'm not going to go for that. Meanwhile, when I have a look at the comment section, I can see Dr. Matthew George, Dr. Saugada Majumdar, Dr. Shreya, Dr. Abhinaya, many of you have rightly identified it as a relative bradycardia. So this finding is a relative bradycardia, which is again strengthening your diagnosis. And what is the diagnosis? Diagnosis of enteric fever. So the clinical history of this disease is suggestive of enteric fever. All the features are suggestive of enteric fever. In the first week, enteric fever, it has to be the blood culture. Okay, right. Coming to the next question. A 40-year-old farmer presents with fever, severe calf muscle pain, and retroorbital discomfort. On examination, there was conjunctival suffusion, and laboratory investigation shows neutrophilic leukocytosis. What is the most likely diagnosis? My dear children, last time in NEET PG, many students saw this fever and retroorbital discomfort straight away they decided on choosing dengue. But is it actually dengue? Please look. Severe calf muscle pain. Is it a common feature of dengue? No. Conjunctival suffusion. Is it a common feature of dengue? No. And point is neutrophilic leukocytosis. In dengue, we know that there is leukopenia. Now, these points are against dengue and these points are favoring leptospirosis. You can have calf muscle pain, calf muscle tenderness in leptospirosis. And in leptospirosis being a bacterial infection, usually you get leukocytosis. Rarely, even the WBC count can be normal, but again, neutrophilic leukocytosis is expected. But dengue, you're not at all expecting any sort of leukocytosis. So don't think that dengue is the only infection which has retroorbital pain. Even in leptospirosis, you can very well have. Okay, right. And malaria, anthrax, again, the features are not suggestive of that. Okay, let us go to the next question. A 32-year-old sexually active woman presents with dysuria, lower abdominal pain, and increased urinary frequency. Urine culture reveals Staphylococcus saprophyticus with a colony count of 10 raised to 4 colony forming units per ml. What is the most appropriate next step in the management? Is it diagnose and treat as UTI, or is it like sample likely contaminated, repeat with fresh sample? Or option C, asymptomatic bacteriuria, reassure the patient no treatment is needed? Or is it that no, it's a normal commensal and no treatment is required? See, first of all, you have to understand it is a sexually active female. And sexually active females are predisposed to Staphylococcus saprophyticus infection. We know that overall E. coli is the common agent that causes UTI, but in a sexually active woman, one of another important cause, etiological agent that you should consider is Staphylococcus saprophyticus. And the patient is very well symptomatic. You can see all the features of UTI are there. So this is going to be a symptomatic UTI. And when you have a symptomatic urinary tract infection, what is going to be the cutoff for the colony forming units? It is 10 raised to 3. 10 raised to 5 is when the patient is asymptomatic, but when the patient is symptomatic, anything more than 1000 is definitely significant. So the answer is you have to consider this as a UTI. You diagnose it as UTI and you treat the UTI. You cannot take it as a contaminant. Staph saprophyticus is not a contaminant in a patient who is sexually active. You cannot take it as asymptomatic bacteriuria. My dear children, already given that the patient is having symptoms. Use your logic. Can you take it as option C? Can you say that the patient is asymptomatic? No. Patient is very well symptomatic. Normal commensal, no treatment required. Again, it is a false. The thing is, you have to diagnose it as a UTI and you treat it as a UTI. Next question, a very, very interesting question. I want all of you to be very attentive, very, very attentive for this question. I want to see how many of you answer this. As I read out the question, I want to see how many of you are answering in the chat box. Look at this. 18-year-old boy from Rajasthan weighs 50 kilogram. Okay, he's from Rajasthan. He's weighing 50 kilogram. He is diagnosed with a mixed vivax and falciparum malaria. Now we have learned about management of falciparum malaria, vivax malaria, but this time they are talking about a mixed infection, that is with both vivax and falciparum. What is the most appropriate treatment regimen on day 2? Day 2. Now, what about the options? You look at the options. I want my children to see or to comment what is the answer. I'll just wait for your comments. But, as I go through the comments, I'll just, give you an overview about the management of Vivax and falciparum. In case of Vivax malaria, number one, you can give chloroquine. Correct or not? You can give chloroquine, which is given 25 mg per kg divided over 3 days. 10 mg per kg on day 1, 10 mg per kg on day 2, and 5 mg per kg on day 3. No doubt about it. And you must give primaquine, and it is given for a dose for a duration of 14 days because you have to kill the hypnozoites. So it is given at a dose of 0.25 milligram per kilogram body weight daily for 14 days it is given. Correct or not? 14 days it is given. Now coming to the the falciparum malaria, it's not going to be chloroquine. You're going to give the ACT, okay, the artemisinin combination therapy. Now, if the patient was in the northeastern state, I would have gone for a combination of artemether lumifantrin, okay, because when it comes to falciparum malaria, when it comes to falciparum, if the patient is from the northeastern state, you will go for a combination of artemether plus lumifantrin. In all other states, you will go for artesunate plus your sulfadoxine pyrimethamine. Okay, pyrimethamine. And remember, when you give artesunate, it is 4 milligram per kg once daily for 3 days plus sulfadoxine pyrimethamine, but it is only given on day 1. It is only given on day 1, and primaquine 0.75 milligram per kg body weight on day 2. Now what you have to understand is, when it comes to this particular case where you have got a mixed infection, Vivax and falciparum. So what are you going to give? Are you going to give chloroquine? No. You're going to give an artemisinin based combination therapy, and it is going to be a artesunate plus sulfadoxine pyrimethamine. But what makes this question interesting is that they are asking specifically on day 2. Now you tell me, sulfadoxine pyrimethamine, is it given on day 2? No, I have specifically told you this is only given on day 1. So the last two options which contain sulfadoxine pyrimethamine is already out of the question, because on day 2 you are not going to give. Now you will give artesunate because 50 milligram into 4, okay, 50 milligram, 4 tablets, correct or not, because it is 4 mg per kg, so 4 tablets. So it can either be option A or option B. Now remember, you know, when you are giving this primaquine, when you have a mixed infection, you will give it for longer duration, 14 days, because unlike in falciparum where you are giving it only on day 2, here you will have to give a longer duration. So you will use artesunate, but primaquine is to be given in the Vivax dosage. Remember, this is the golden point. Primaquine in a mixed infection is to be given according to the Vivax dosage. And here what you do is that for an adult, what you do is it is 2.5 milligram 6 tablets, because it is going to be 15 milligram daily for an adult. Okay, so this is 0.25 mg per kg. That is an adult. It is actually around 15 milligram, and 15 milligram means you will give 6 tablets each of 2.5 milligram. So on the second day, you will give 15 milligram. So you'll give daily 15 milligram, 15 milligram, 15 milligram up to 14 days. So for this question, the answer is going to be option A. I repeat again, it is going to be 0.25, not 0.75 mg per kg. It is going to be 0.25 mg per kg. In an adult, it has to be 15 milligram daily for 14 days and 2.5 milligram 6 tablets. Now, if my children, if you have understood this, you give me a thumbs up. I'm expecting your thumbs up. Just waiting for your answers in the, your thumbs up in the chat box. So it's going to be a tricky question that was asked in NEET PG 2024. Just give me a thumbs up if you have understood. Okay, right. So this is just an algorithm which I have taught you in my lectures, as well as the videos on the treatment of malaria, both the complicated and the uncomplicated form. Coming to the next one, a 30-year-old male, male patient, okay, 30-year-old male patient is found in a railway station. So he was found lying in a railway station, exhibiting hot, dry skin, elevated body temperature, dilated pupils, and slurred speech. Which of the following is the most likely cause of the symptoms? Again, there is a problem with the video. Just let me get it right. Okay. What is the most likely cause of these symptoms? Now, you've got dilated pupils here. Dilated pupils. So when you get dilated pupils, hot, dry skin, elevated body temperature, you're again thinking about an anticholinergic toxidrome. That's what you call it. You call it to be an anticholinergic toxidrome. Anticholinergic toxidrome. Toxidrome. That's what is happening here. Because cocaine will have more of a sympathetic stimulation, right? And here you are having a hot, dry skin. So what is the answer? It is going to be datura poisoning. It is going to be datura poisoning because it will contain this anticholinergics like atropine. So the patient has got all these muscarinic side effects, both peripherally as well as centrally. So that is what you are actually seeing, anti-muscarinic effects. So that is, datura poisoning is the answer for this question. Okay, right. Coming to the next question. A 35-year-old male presents with altered mental status, tachypnea, tachycardia, hypertension following the ingestion of unknown substance. Laboratory evaluation shows uh, high anion gap metabolic acidosis with hypocalcemia. Again, a straightforward question. This is nothing but ethylene glycol toxicity. And why do I say that it is ethylene glycol toxicity? Can somebody tell me why is it ethylene glycol toxicity? Because you will have oxalic acid, glycolic acid, all these acids being formed, and this will contribute to the high anion gap. You are having, acid being added like oxalic acid, glycolic acid. So that is going to cause high anion gap metabolic acidosis. And this oxalic acid can go and bind with the calcium. So when it goes and binds with the calcium, it results in hypocalcemia. It results in hypocalcemia and all other features. It is an alcohol. You will have all these features like altered mental status, tachypnea, tachycardia, hypertension. Okay, right. I've already taught you that ethylene glycol is one of the causes of a high anion gap metabolic acidosis. Option C is the answer. Okay, coming to the next question. And again, similar question to what we just discussed a couple of questions back, but came in the other shift of NEET PG. 25-year-old male who is a drug addict presents to the emergency department with unknown poisoning. Examination revealed dilated pupils. Now, dilated pupils. Here also you have got datura in the options, but are you going to go for datura? Are you going to go for datura? No. Why? Because that cannot explain sweating. It cannot explain tremors, and you are seeing that there is sympathetic activation. So this is not an anticholinergic, but this is a sympathetic toxidrome. There is sympathetic overactivation, sympathetic toxidrome. That's how you differentiate between the anticholinergic and the sympathetic toxidrome. Anticholinergic will be having dry features, but here you're having sweating. So what do you think? It is going to be cocaine. Okay, it is going to be cocaine. So sympathetic stimulation is there. The answer is going to be cocaine. That is going to be option D as the answer. Okay, right. So coming to the next question. A 30-year-old male presents to the emergency department following a head trauma from a road traffic accident. Shortly after admission, he develops generalized seizures, and a CT scan reveals cerebral edema, which is the most appropriate osmotic agent for managing cerebral edema. So usually after a head trauma, intracranial bleed, stroke, the cerebral edema is usually, after these road traffic accidents, it's usually a cytotoxic edema. Okay, because there are three types of cerebral edema: cytotoxic, vasogenic, interstitial. So the other edemas are vasogenic, interstitial. Following a head trauma and some sort of a cerebral contusion, you get cytotoxic edema. And the most appropriate agent for managing the cerebral edema, that is cytotoxic edema, is mannitol. That's the answer, option A. Okay, right. So coming to the next question, 40-year-old chronic alcoholic is brought to the emergency department in a confused state. There is some sort of nystagmus and unsteady gait. Unsteady gait, probably they are meaning it is ataxia. So when an alcoholic presents with confusion, ataxia, nystagmus, you are thinking about a diagnosis of Wernicke's encephalopathy. And the patient is also having hypoglycemia. What is the most appropriate immediate management? For Wernicke's encephalopathy component, you have to give thiamine. For the low blood glucose, you have to give dextrose as well. But what are you going to administer first? Is it going to be thiamine first or dextrose first? Always remember, it has to be thiamine first. Okay, because if you administer dextrose and then you administer thiamine, dextrose will help, in correcting the hypoglycemia. But for this serious condition like Wernicke's encephalopathy, what happens is that the thiamine that you administer may be utilized in the metabolism, because you know that thiamine pyridoxal phosphate, TPP, is important in this glucose metabolism. So you do not want this thiamine to be used for that. Thiamine is important for this serious condition like vernix encephalopathy. So you give thiamine first, let the body get thiamine, and immediately after that, without any delay, you have to give dextrose as well. So it has to be thiamine first, followed by IV dextrose. If you go for option B, if you first give dextrose, body gets the dextrose, immediately it gets the thiamine. This thiamine will be utilized in the metabolism of dextrose. That is why the option A is the best answer. Okay, right. Next, an adult presents with these striking physical features, and yes, striking physical features: arm span longer than height, chest deformity resembling a pigeon chest, that is pectus carinatum, and ophthalmological examination showing some sort of a lens subluxation. What is the protein that is commonly going to be affected? What do you think? It is likely to be fibrillin 1, because the diagnosis is going to be Marfan syndrome, and for Marfan syndrome you are going to have a mutation in the fibrillin 1 mutation in case of Marfan syndrome. Okay, so the answer is option B. Coming to the next question, 40-year-old male is being treated for hypertriglyceridemia, and as a part of the treatment, probably the patient has got some problems like flushing. Patient has got hyperglycemia, hyperuricemia, and elevated liver enzymes. And what do you think? Which drug is most likely responsible for this? Is it atorvastatin, ezetimibe, fenofibrate, niacin? Remember, these are all side effects of niacin, which can cause, that is your nicotinic acid, which is used in the treatment of triglyceridemia, which can cause flushing, hyperglycemia, hyperuricemia, and even elevated liver enzymes. And now coming to the next question. Uh, Aprepitant is a drug used in the management of chemotherapy-induced vomiting. They have asked what is the mechanism of action of this drug. It is NK1 antagonist. It is NK1 antagonist. One second. I think it's an internet connection. One second. Okay. Sorry for the technical issue here. So, aprepitant is an NK1 antagonist, a neurokinin receptor antagonist. So basically for chemotherapy-induced MSS, you can go for the NK1 receptor antagonists that include aprepitant and the other drugs like fosaprepitant, netopitant, and rolapitant. So all of them will actually end with pitant. Okay. Why it is pitant? Because it is targeting the substance P, which is a type of neurokinin. Okay. So the answer for this question is option C, right? Coming to the next question, uh, we are discussing these miscellaneous questions now. Okay. So which anticoagulant is recommended for a pregnant female at 30 weeks of gestation who developed left lower limb swelling with calf tenderness and venous Doppler suggestive of deep venous thrombosis? What do you think is the answer for this? The patient is at 30 weeks of gestation. Now, all of you know that in the first trimester, what is preferred? It is only going to be your heparin. So either your unfractionated heparin or low molecular weight heparin is preferred. You're not going for warfarin because of the risk of teratogenicity and the Contradi syndrome. Whereas in case of second trimester, what do you think? Second trimester again, here still low molecular weight heparin is preferred over warfarin, no doubt. Do not be under the impression that yes, since you can give warfarin in the second trimester, do not think that warfarin is superior to LMWH. It is still LMWH that is preferred over warfarin. So ideal scenario, you have to be giving LMWH. But if there is some problem with the compliance, patient is not agreeing to take daily injection, then okay, you can go for warfarin. And third trimester again, you are going back to heparin. Okay, third trimester, again you are going for your heparin. Okay, either unfractionated or LMWH. But second trimester, if the question is specifically which anticoagulant is recommended, it's still LMWH. I'm still going to prefer low molecular weight heparin. Okay, right. Coming to the next question, which is going to be the last question. I think the 100th question, because I've made a collection of 100 questions of medicine. Remember, NEET PG 2024, we had two shifts, the morning shift and afternoon shift. So from both these shifts combined, I've got 100 questions. So I want all my children, when you go to the exam, you watch these 100 questions. Not just that these questions are going to be exactly repeated, but these are 100 high yield topics and you have to learn it before you go for the exam. Okay. So this is your last question, the 100th question. Already I've discussed in the part 1 and part 2 of the recalls the other questions, and this will be the last one. A pregnant female at 37 weeks of gestation has a prosthetic heart valve and is currently taking warfarin. She has presented for routine antenatal evaluation, so she's not having any problem as of now. She's not in a labor pain. So what is the most appropriate management recommendation at this particular stage? Is it immediately induce labor or continue warfarin therapy, perform lower segment cesarean section LSCS, or switch from warfarin to LMWH? Well, it is simple. It is now in third trimester, patient in third trimester. I will not be going for warfarin. I will be switching from warfarin to either unfractionated heparin or low molecular weight heparin. Why? Because in third trimester, as the patient nears the delivery, you will have to give an anticoagulant which has a definite antidote, and you can go for protamine sulfate. So better you go for option D, that is switch from warfarin to low molecular weight heparin. Okay, right. So that is what I want you to know. So I hope all of you have been benefited by the three the videos that I have done system wise. In the first set, second set, and third set, we have discussed all these important recall questions. So I wish good luck to all my dear children appearing for the exams, and thank you so much. And yeah, thank you so much everyone for joining. Yeah, Grace, Indu, Tejas, Ajit, Sindhu, Monica, Ananya, Sharon, all of you, thank you so much for joining. So thank you so much, and wish you good luck for your exams as well. All the best. All the best. Ajit, all the best. Ajit, all the best. Stardust, all the best for your exams. All the best. So glad that you like the sessions. These recall topics are very important. Okay, I want you to go through it. Ananya, Archana. Okay, thank you so much, everyone. All the best. Thank you so much.